Good evening to all. Myself, Dr. Lokesh Kumar Agrawal from Jaipur, Rajasthan. First, I would like to say thanks to Mr. Saurabh Singh, co-founder and director of Rare Disease India Foundation, for giving me this opportunity to moderate the session. I am clear?
Yes.
Saurabh? Okay, thank you. So today on 15th April, on occasion of 9th Annual International POMPE Awareness Day, I want to welcome all the dignitaries, Dr. Ashok Balodi sir, our chief guest, our keynote speaker, Dr. Kaushik Mandal sir, and Mr. Saurabh Singh ji, and all the participants. This year theme is International POMPE Voices. POMPE disease is a rare disease quantum with variable rates of disease progression and different age of onset. POMPE being the deadliest and costliest disease among 50 plus LSDs to treat and maintain. Incidence is around 1 in 40,000 and also known as glycogen storage disease disorder type 2. POMPE is inherited as a autosomal recessive pattern caused by deficiency of acid alpha glucosidase enzyme due to mutation in GAA gene. It is named after Dutch pathologist Dr. J.C. POMPE, which first described it in 1932. First symptom can occur at any age from birth to late childhood. The earlier onset compared to later onset is usually associated with faster progression and greater disease severity. All three type of muscles are affected. They have characteristic heart cardiac problems due to heart enlargement. In addition to generalized muscle weakness and life expectancy of less than 2 years, if untreated in classical infantile POMPE disease. The late onset POMPE disease really manifests cardiac problems, but gradually leads to walking disability and reduced respiratory function. Enzyme replacement therapy is only treatment presently available. We will discuss later on it. So, not taking much time, I want to invite Mr. Saurabh Singh, co-founder and director of Rare Disease India Foundation. He is a well-known personality who is doing very hard work to assess the treatment for rare disease patients in India by formulating this organization. So, over to Mr. Saurabh Singh. Sir.
Thank you, Dr. Lokesh. Hello, everyone. I am Saurabh Singh, co-founder and director, Rare Disease India Foundation, as Dr. Lokesh has said. I welcome everyone on behalf of Rare Diseases India Foundation to be here today on the special occasion of International POMPE Awareness Day with a mission to create awareness in the country. Every year we celebrate International POMPE Awareness Day on 15th of April. Rare Disease India Foundation is a patient advocacy group. It is established in 2019, and this is a non-profit organization which raises awareness for rare diseases in the country. There are around 7,000 to 8,000 rare disorders, and it is mostly genetic. 6 to 8% of population in India is affected with rare diseases, and 72 to 96 million people suffering by rare diseases. Why awareness is important? If we know about these diseases in advance, we can certainly control or manage these diseases somehow. Genetic counseling. If the suspected couple goes to medical counselor on time, there are chances to get some remedies. Early diagnosis. If the diagnosis can be identified early, the medication may start early. Lack of awareness, including medical fraternity. It is the major obstacle on the way of rare diseases. There are lack of awareness about rare diseases, including medical fraternity, patients, and general public. Patients has to visit hospital to hospital for the diagnosis every time. There are so many challenges in rare disease in the country. Either there is no treatment available or the treatment is unaffordable by an individual in the country. Early diagnosis of disease is also one of the major challenges because the symptoms generally appears after 2 to 3 years of age. Life expectancy is very less in these diseases. Still, we are struggling for a proper rare disease policy in the country. The cost of the medication comes in crores, which is unaffordable by an individual. No insurance company covers these diseases. Rare Disease India Foundation, RDIF, appeal everyone to let's join our hands together to spread awareness about rare diseases in the country. So to discuss in detail about these burning issues, today we have the expert doctors from India and abroad. I welcome our chief guest, Dr. Ashok Vilodi, from former consultant pediatrician from Great Ormond Hospital, Children Hospital, London, UK. Our another speaker is Dr. Kaushik Mandal, who is medical genetics in SGPGI, Lucknow. And last but not the least, moderator for the session is Dr. Lokesh Agarwal, who is Senior Medical Officer in JK Lone Hospital, Jaipur. Over to you, Dr. Lokesh.
Thank you, Mr. Saurabh Singh. Now I want to request IT team to play a video of a patient story.
Pompe disease is a rare genetic disorder that causes muscle weakness and trouble breathing. Largely, it affects the heart and muscles.
My name is George Jacob Thomas. I'm 23 years old and I have Pompe's disease. It was in 2003. I was 7 years old that time. I used to find it difficult to get up from sitting position. I used to have difficulty climbing steps. So I used to literally hold on to the railings and pull myself.
We as parents didn't know whether there was going to be any cure for his problem.
Finally, in 2007, we did a skin fibroblast test and a dry blood spotting test in Trivandrum. We then sent the samples to Duke's University. They then performed the test over there and they confirmed that it was Pompe's in 2007. My parents and the doctor treating me at that time then finally approached Sanofi Genzyme, who then agreed and transferred the medicine, and thus I received my first enzyme replacement therapy under the INCAP program in 2009. I had lost all hope, but because of the ERT, I'm back to my normal life, and my health has not deteriorated anymore. It has improved, it has then stabilized, and I enjoy my life now each day as it comes.
Early treatment gives patients their lives back and brings more hope and joy to them and their families.
Thank you. Now, I want to invite our first speaker of the day, Dr. Kaushik Mandal sir, is a MD Pediatrics and DM Medical Genetics. He is working as additional professor, Department of Medical Genetics, Sanjay Gandhi SGPCI Institute, Lucknow. The topic is natural history of Pompe disease and role of timely diagnosis of late onset Pompe disease and impact on disease progression. Over to Kaushik Mandal sir.
Good evening, Doctor. Good evening.
Good evening, sir.
Hope you can see my slides.
Yes.
So we'll be talking about the natural history of Pompe disease. And as we have seen in the previous video, that if it is diagnosed within time, there is hope. We'll be discussing about infantile Pompe disease in this session. We'll be discussing about the pros and cons, how dreaded the disease is, what will be the outcome if we can start it early, what will be the outcome if we miss the window period of diagnosis, and what is the role of newborn screening in this disorder. So this presentation is entirely targeted for awareness. The facts and figures are from different sources and are for academic purposes and for awareness, and they should not be quoted without verification from authentic sources. There is no financial relationship related to this lecture. There is no conflict of interest. So as we know, this is a genetic disorder. So what is a gene? Gene is a part of DNA which encodes for a protein. And everything in our body, from structural proteins to enzymes, hormones, they are all proteins in nature. So when in a metabolic disorder, the enzyme is deficient, either one substrate which needs to be broken down to a different substrate cannot be done with that smoothness, so that substrate accumulates, or there is deficiency of the substrate which is ought to be made from the previous substrate. So enzymes are catalysts and they are required for very many functions in the body. Lysosomes are.
Sir, make it a slideshow mode, sir.
Oh, it's in the slideshow mode only. You can see the slides moving.
No, sir. You just
No, sir,
press
no, sir.
F5. You just press F5. This becomes slide selector.
So can you see it now? Or I will. Yes. I will do it again.
No, sir. You sir just press F5.
I've done that.
Sir, after clicking the share screen button, just you click screen.
Now you can see the. Now you can see my screen, but not the screenshot. Now you can see slides. Slideshow mode.
No, sir. If you see 73% of your battery, there is an icon. You please press that button and your slide show will start. 73%
Yes.
showing right side corner.
Yes, there is a slideshow button. I can see my slideshow. So what I will do, I will share my entire screen.
Yeah, no problem, sir. You can share one by one by pressing 1, 2, 3, slide number 1, 2, 3. Yes, it is okay, sir. It is okay.
So lysozymes are contained in the lysosome and they break down large molecules into smaller molecules. So when these enzymes are deficient, so the larger molecules accumulate. Lysosomes are present in various parts of our body. I mean in all cells of our body, and they get these large substances get accumulated in various parts of our body, including organs like liver, spleen, heart, bones, and also in the CNS, that is central nervous system, and all manifestations are there. These are the various forms of lysosomal storage disorders. We all know about mucopolysaccharidosis type 1 to Gaucher disease. So all of them have large organomegaly. But for type 2 glycogen storage disease, which is also called POMPE disease, this accumulation is not only in the organs, unlike mucopolysaccharidosis or Gaucher disease, they are in the heart and they present with hypotonia or decreased tone of the body. So lysosomal storage disorders are classified in these various groups. POMPE disease also a glycogen storage disease, which is classified under lysosomal storage disorder. So collectively, lysosomal storage disorders are common, 1 in 5,000, and individually they might be rare. There are more than 50 distinct disorders. Most common is Gaucher disease. And if we can see the incidence of POMPE in different populations, it comes roughly to 1 in 40,000 to 1 in 1 lakh. in different populations, where these are the various studies where this population incidence has been stated. The diagnostic approach of lysosomal storage disorders is a family history. As we know that Fabry and Hunter are X-linked, POMPE is autosomal recessive. So the clinical features of this and radiology. So I am not talking about POMPE now, only about the all lysosomal storage disorders as a whole, and they have a very characteristic or similar diagnostic approach, which also contains biochemical tests like urine tests and enzyme assays, and then molecular testing. So enzyme assay is done like this, but for Pompe disease, dried blood spot is fair enough to get an enzyme assay done, unlike many other where the leukocyte or the plasma is being used. So Pompe disease can be classified by the age of onset, organ involvement, severity, and rate of progression into infantile Pompe, where the individuals start having symptoms before the age of 12 months, and late onset Pompe, where the individuals have symptoms after 12 months. And very characteristic of infantile Pompe is associated cardiomyopathy. So infantile Pompe is before 12 months, and they typically present with a median age of 4 months. That means most children by age of 4 months will present with hypotonia, that is decreased tone, generalized muscle weakness, feeding difficulties, failure to thrive, failure to gain weight, respiratory problems, hypertrophic cardiomyopathy. And without treatment by enzyme replacement therapy, infantile Pompe commonly results in demise by the age of 2 years. So that children typically looks like this. When they are pulled to sit, they cannot lift their head lags, they have decreased tone in all parts of the body. So these are the few percentages, what is there when it is being suspected, like poor feeding, failure to thrive, motor delay, muscle weakness, respiratory difficulties, cardiac problems. Cardiac problems may be found or picked up by shortened PR interval in ECG or white QRS complex, cardiomegaly in X-rays, left ventricular outflow obstruction or cardiomyopathy by looking at the echocardiogram. So these are the various percentages of presentation, and as you can see in infantile Pompe disease, cardiac anomalies are very high. You can see cardiomegaly almost in 100%. So there will be large heart, and most of them will have left ventricular hypertrophy. So in echo, left ventricular hypertrophy can be seen. There would be respiratory distress, a very large chunk of these children. Some of them might have enlarged tongue, though we don't see it very commonly, because by the time we start looking at the enlarged tongue, these children are very, very sick. The various differentials of this disorder is spinomuscular atrophy, which looks very similar. Type 1, they present with hypotonia, and again, it is a very common disorder. Various other central nervous system abnormalities, chromosomal anomalies like Prader-Willi, they have feeding difficulties, some paroxysmal biogenesis disorders, various forms of congenital myopathies and congenital muscular dystrophies. There is another lysosomal storage disorder called Danon disease, which is X-linked, but they have intellectual disability, but the features may be very similar to the late onset Pompe disease. Then carnitine uptake disorders, again, carnitine uptake disorders have CNS, central nervous system problems, unlike that much of Pompe disease. Glycogen storage disease type 3A and 4, they also present with hypotonia, hypertrophic cardiomyopathy due to various other causes, might mimic Pompe disease echocardiographically. Then myocarditis, various mitochondrial respiratory disorders, they can have features similar to Pompe disease, but infantile Pompe, once we have seen, we don't miss it. But one very common differential is the spinal muscular atrophy, type 1. So late onset Pompe is after 12 months. They present very similar to Duchenne muscular dystrophy, or proximal muscular dystrophy group of disorders, they have difficulty in sitting up, standing from sitting position, as you have seen in the video. And when they have high CPK levels, it is being really confused with one of those muscular dystrophies. Cardiac involvement is uncommon in late onset Pompe disease. The supportive laboratory findings is by a positive newborn screening, which is a rapid and sensitive analysis of acid alpha glucosidase enzyme activity can be performed on dried blood spot, and confirmation of deficiency of this enzyme activity is detected, and by which is detected by dried blood spot can be rechecked or confirmed by a molecular method. Though it has been told that it can be done from peripheral blood leukocytes or skin fibroblasts, uh, again to confirm it, but molecular diagnosis is fair enough after you do it, have seen it in a dried blood spot, and it is almost comparable with the test done with tandem mass using tandem mass spectrometry. Serum CPK level is high, really high, like muscular dystrophies in infantile Pompe. It may not be so much high in late onset Pompe, and sometimes it can be normal also in late onset Pompe. Urine oligosaccharides, elevation of a specific glycogen, elevation of a specific urinary oligosaccharide is seen in Pompe disease, however, it is also seen in other glycogen storage disorders. So diagnosis is by clinical and laboratory methods, and also by a molecular testing. So molecular testing is done, this I have already discussed. If the enzyme level is less than 1% of the control, this is infantile Pompe disease. And if it is more than 1%, they generally present as late onset Pompe disease. The gene sequence analysis will detect it in a very large 80 to 90%, and there can be small deletion duplications as well, which is detected by other methods and not by sequence analysis. There is a rough rule that if there is biallelic GA pathogenic variants that produce no enzyme activity, they will produce infantile Pompe, and those variations which will produce some activity will have late onset. And infants who have infantile onset Pompe with no CRIM, that is cross reactive material, I will discuss it later on, are likely to have two null variants, that means two stop codons in both the alleles, and they are very, very severe. Some generalization about genotype phenotype is that GA pathogenic variants that introduce mRNA instability, such as a nonsense variant, are more commonly seen in infantile Pompe, as they result in nearly complete absence of this enzyme. And missense and splicing may result in either complete or partial absence. So they can present as infantile or late onset Pompe disease. Excuse me. So the guidelines for to have what is the management is can be found in 2006, but they look into cardiomyopathy, arteriopathy, conduction disturbances, the muscle weakness, difficulty with communication, nutrition feeding, nutrition respiratory insufficiency, so on and so forth. The natural history or prognosis of infantile Pompe is that the newborn screening, when it is picked up, it is good, because if you start enzyme replacement before 2 weeks, it has significantly improved the gross motor function. The earlier we start, the better is the prognosis, and there are studies which tells that if you start before the age of 6 months and before the need for ventilator assistance, a vast majority improved survival, improved ventilator independent survival, and reduced cardiac mass, and a significantly improved acquisition of motor skill compared to an untreated cohort. Longer term survivors who underwent early ERT may show sustained improvement in cardiac and motor function. So ERT reduces cardiac mass ERT reduces cardiac mass in a very large group of children, and ERT results in increase in PR interval and a decrease in left ventricular voltage. While the long-term prognosis is yet unknown, but it has been shown that ERT improves survival. CRIM status, that is cross-reactive immunologic material status, is supposedly to be done prior to initiating ERT, though we cannot delay the start of ERT as soon as the diagnosis is made, because if CRIM negative, if a person or a baby is CRIM negative, they require modified therapy protocols using immunomodulation early in treatment course, optimally before the first infusion. Multiple immunomodulation protocols are in use, most of which use rituximab and some additional drugs. Two ways to determine the CRIM status of an individual is by protein quantification by an antibody-based method or by molecular genetic testing. Gradually, it is being used that molecular genetic testing is coming in vogue. So enzyme replacement therapy is available in two forms, myozyme and lumizyme. It's the same enzyme. Lumizyme is marketed in US. It is administered at the dose of 20 to 40 milligram per kg per dose every 2 weeks, and many individuals are now treated with higher doses as well. The complications are infusion-associated reactions and the development of antibodies. So infusion reactions happen to be more common with IgG antibodies, and development of IgG are less common, but maybe associated anaphylaxis requiring life support measures at times. And as we have told that some infusion related reactions can be mild and can be treated with antipyretic, anti-hemolytic glucocorticoids, etc. So our experience with POMPE disease is that most of our children who have been referred us have crossed this critical period of 6 months, and they were infantile POMPE before we could get a CRIM status. We had to start infusion, but most of the children are lost because we really did not know the CRIM status, and before 1 or 2 infusions only we could give, and most of them went into either ventilator support or other forms of pneumonia, respiratory failure like that. So it is very, very important that we diagnose it very, very early, not only through clinical history, or we should have a pedigree. If there is a similar baby in the family, we should do a molecular testing. We can also do prenatal in them, in those families. But a newborn screening to detect this disorder is very, very important because time is very critical. So these are the few studies which we could see that the outcome is very good. The earlier you start, the better is the outcome, mostly the cardiac status, and probably the cardiac events and the respiratory events are the things we should take care of to make these babies survive long. And for all these families, prenatal testing is very, very important. So mutation testing and doing a prenatal and looking at the same mutation. So in the left side is a CVS. We put a needle in the coronary villus and take out sample this and extract DNA. The right hand side is amniotic fluid. So these things we do in our center. But prior to that, once we get the child, we do the mutation so that we know what the baby has and what we are going to look for. So thank you so much. My acknowledgements for the organizers who have organized this, the funding agencies who have supported various children, the patients, the children, the families, my colleagues who work with me, my institute, and this is my biker group. I do serious biking for last few years. And as this is a team, so it is a team effort. What I have shown is that it's a team effort to work on these type of rare disorders. So thank you so much.
Thank you, sir. Now I want to welcome Dr. Ashok Palladi, sir, our keynote speaker and chief guest of today's program. It's our pleasure that sir is here with this occasion of International POMPE Awareness Program. Sir is working as a consultant pediatrician metabolic unit Great Ormond Street Hospital for Children in UK. Sir is also an honorary reader clinical and molecular genetic unit UCL Institute of Child Health. Sir has written many articles in renowned national and international publication and RS also various chapter in books. So sir's topic is recent advantage in POMPE disease. So hand over to Ashok Baladi sir.
Thank you, Lokesh. Good evening, everyone. I would like to thank Saurabh for inviting me to give this talk. Now, let me just make sure that can everyone see the slide?
Yeah.
Okay, so I'll start. I've been asked to talk about some recent advances and challenges in POMPE. Now, there is quite a lot in this field that is happening, and I've just selected a few areas that I think are interesting areas to talk about. So I've divided my talk into three sections. What are the challenges that have arisen? What is the basis for tackling or addressing them, and what progress has been made so far? So the underlying problem is that as we treat these disorders with enzyme replacement therapy, as Dr. Mandal has outlined, these patients are surviving, but we are seeing new challenges that have to be addressed. So the challenges that I've identified are three: emerging phenotypes, CNS involvement, and resistance to treatment. So let's talk about emerging phenotypes to start with. So as we treat these patients, their life expectancy is improving, but new clinical problems are arising. So in infantile disease, these are the problems that we are seeing: varying degrees of muscle weakness, spasticity, scoliosis, hearing loss, speech and swallowing defects, and really, quite importantly, cognitive decline. So here's some slides of progression of the distal spasticity from Alex Broomfield's paper a few years ago. And this is a slide of a patient who had infantile onset Pompe disease and has been followed up on enzyme replacement therapy. And you can see these periventricular white matter changes. And many teams across the world are now reporting this. And this may be associated with cognitive impairment and also sometimes gray matter changes. Now, in late onset Pompe, again, we're seeing an emerging phenotype with small muscle involvement, which may be lower airway or vascular, hearing loss, cognitive impairment, peripheral neuropathy, GI problems. So I'm just mentioning these, I'm not discussing these in detail. This is an important and interesting patient. He had a late onset Pompe and had been on a ventilator for many years. And he then developed progressive ventilatory failure with diaphragmatic failure on the ventilator. And post-mortem showed extensive changes, as you can see, in the medulla, the cervical cord, thoracic cord, and the lumbar sacral cord. So the conclusions of the team that reported this was that there was neurophysiological evidence of functional denervation of the diaphragm and histological evidence of neurodegeneration and motor neuron death accompanied by loss of diaphragm myofibers. This is a very important case. So I think we can be clear that there is CNS involvement involving the motor neurons, the neuromuscular junction, vascular tissue, white and gray matter, and the ventricular system. So it's clear that there's CNS involvement in IOPD as well as LOPD. So how can we study this? Well, two ways. One is using the animal model, and the second is using induced pluripotent stem cells. That's iPSC. So let's talk about a study that's been done in the animal model. This team looked at ultrastructural and diffusion tensor imaging studies, and they found that there was axon abnormalities in Pompe disease mice. And they postulated this mechanism. So here on top, you have a control mouse with normal levels of glycogen in the astrocytes and neurons. And below, you have the PD mouse. And glycogen is accumulating in the neurons and astrocytes, which then results in axon degeneration and resulting thinning of the corpus callosum and other white matter changes, and possibly gray matter changes. But this is just a postulate, and this needs to be now proven. Looking at iPSC, this team has developed iPSC an iPSC model that reflects CNS involvement in Pompe disease. Very useful for further studies. And now the third challenge is resistance to enzyme replacement therapy. There are three important reasons for resistance. The first is CRIM status, and Dr. Mandel has quite nicely covered this, so I'm not going to discuss it. The second is autophagy. What is autophagy? It's a Greek word meaning self-devouring, and it's the process by which the cell breaks down unnecessary or dysfunctional components. So the cell's components are constantly recycling and being broken down. And this term was first coined by Dedieuve, who was in fact the discoverer of the lysosome in 1963. And Professor Osumi was awarded the Nobel Prize in 2016 for his discoveries and work in autophagy. And now there are four broad types of autophagy: macroautophagy, micro, chaperone-mediated, and mitophagy. But really, so these are the three common types: macroautophagy, chaperone-mediated, and microautophagy. But I'm just going to talk about macroautophagy, which is the most important one, especially where Pompe is concerned. So what happens in macroautophagy? Well, first you get whatever the material that needs to be broken down. You first get an isolation membrane, and then the forming of a vesicle, and then an autophagosome forms, which contains the material that needs to be broken down. This then fuses with the lysosome to form the autolysosome, and inside the autolysosome, the lysosomal enzymes break down the material that was in the autophagosome. So obviously all these processes need to be functioning properly. And many lysosomal storage diseases have impaired autophagy. So either you can have increased formation of the autophagic material, or you can have defective degradation. And on top, I've put Pompe disease, and as you can see, both increased formation and defective degradation are seen. So there are some other diseases in which autophagy is seen, but we're not going to discuss those today. Now, if autophagic material cannot be broken down, it builds up. And this has implications for both cellular function as well as cellular access to therapeutic molecules. And if we therefore reverse this process, it will benefit both cellular function as well as access to therapy. So we need to try and reverse the autophagic buildup. And you can see this progressive autophagic buildup in Pompe disease. So on I will just like to draw your attention to the top row of slides, which refers to LC3. LC3 is a marker for autophagy. Now you can see on the right, the wild type mouse, that's the normal mouse at 24 months, has no buildup. Whereas the knockout mouse, you can see at 1 month, 5 months, and 24 months, the buildup gradually developing. You can ignore the rest of the pictures. Now, autophagic buildup diminishes the effect of ART. How can autophagy be improved? There are two broad approaches. One is genetic suppression, and the second is transcription factor EB. Let's deal with genetic suppression first. So if you knock out, if autophagy is allowed to function normally in patients and in mice, then ART is less effective. But if you knock it out, so the knockout mouse model, in other words, from birth, then ART is highly effective. So if autophagy is not allowed to build up, then ART is extremely effective. And this is one of the reasons why early treatment is, it's not the only reason, but it's one of the reasons why early treatment is so effective in POMPE. The second is TFEB. What is TFEB? Now, we first need to understand a little bit about lysosomal function in this regard. So the breakdown of waste material in lysosomes occurs by acid hydrolysis through the lysosomal enzymes, but also through autophagy, as we've just discovered. Also secretion, but we're not discussing that today. And the last is a very important component called nutrient sensing. What is nutrient sensing? This was first described in 2009, a gene network which regulated biogenesis and function. This is the nutrient sensing network, which is called the CLEAR network. You don't have to pay too much attention to this slide. I'm just to say that there are very elaborate mechanisms for detecting lysosomal stress. And I'll just point out this complex here, which is called the Linus, L-Y-N-U-S. So the Linus machinery is able to respond to cellular stress and starvation. Under stress or under conditions of stress and starvation, waste products build up. Now, increased autophagy is required to eliminate these waste products. And under conditions of nutrient plenty, so when there are no problems, there is less requirement for autophagy. So TFEB is a transcriptional protein, okay? It's able to switch on autophagy, but it can only do this in the dephosphorylated state. And under conditions of nutrient plenty, it's kept phosphorylated and remains in the cytosol. So let's just look at a diagram here. So on the left, green, you have nutrient plenty, and on the right, you have nutrient starvation or stress. So on the left, you can see this molecule called mTOR in green, which is docked to TFEB, okay? Now mTOR, so this is the lysosome, okay? And on top, you can see the plasma membrane. So the lysosome is here, and mTOR is preventing TFEB from entering the cell. Now, when there's starvation, it's a very different scenario. mTOR disconnects from the lysosome, and immediately TFEB can enter the cell. So you see the amount of TFEB in the cell increases, and this starts switching on autophagy. So under conditions of starvation, mTOR dissociates from the lysosome. It can no longer phosphorylate TFAB, and in this state, the dephosphorylated state, TFAB translocates to the nucleus and switches on autophagy and lysosomal gene transcription, and both of these are required. I hope that that wasn't too difficult. You may have to do some reading around this subject. So, experimentally, overexpression of TFAB in POMPE mice has been shown to both reduce lysosomal glycogen content as well as autophagic buildup. So there is potential for TFAB as a therapy in POMPE disease. So last mechanism of resistance to ERT is receptor problems. What do I mean by this? When, as you know, lysosomal enzymes are formed inside the cell. They travel to the lysosome, and there is a normal intracellular process. But when you give enzyme from outside, that's ERT, this is related to Fabry disease, but it's exactly the same for Pompe disease. This requires specific receptors in the cell membrane so that the intravenously administered enzyme can enter the cell. And these cells are known as mannose-6-phosphate receptors. So obviously you need both mannose-6-phosphate receptors on the cell membrane, as well as the mannose-6-phosphate in the enzyme. You need both. Now, in Pompe disease, what happens? Skeletal muscle particularly has a very low density of mannose-6-phosphate and, mannose-6-phosphate receptors, plus myozyme has a very low mannose-6-phosphate concentration. Therefore, uptake of myozyme by skeletal muscle is extremely poor. So how can this be tackled? Well, you can increase the number of receptors, or you can make more efficient enzyme preparations that have more mannose-6-phosphate. So how can we increase the receptor density? Well, one innovative way to do this is by giving beta-2 agonists. An example of this is clenbuterol. And this team from Duke showed some years ago so these are mice who were given, Pompe mice who were given ERT alone or ERT plus clenbuterol. And they looked at the rotarod performance. And on the left side, you can see this refers to the latency. The bottom line refers to mice given ERT only. The top line, ERT plus clenbuterol. And you can see that the latency was improved when clenbuterol was added. Although after 4 weeks, this effect tended to tail off. The same for the weight of the mice. It improved when clenbuterol was added, although again, there was a tailing off at 4 weeks. But nevertheless, this suggested that this could be a therapeutic approach. How can we improve the enzyme? And I refer to these as next generation ERT or next gen. So what are the types of next gen that have been tried? You can either give more mannose-6-phosphate, and this preparation, Nexviazyme or glucosidase alpha, manufactured by Sanofi, has in fact been approved for the treatment of LOPD by the FDA. Or you can improve glycosylation. And this preparation is cypoglucosidase alpha combined with miglustat, and this approach has been developed by Amicus Therapeutics. This is under review by the regulatory bodies. Last of all, I'd just like to mention gene therapy. So what are the advantages of gene therapy over ERT? As you can see, with ERT, there is a need for lifelong infusions. With gene therapy, just one-time delivery. With ERT, it's transient and intermittent. With gene therapy, the levels of enzyme are long-term and continuous. Enzyme replacement therapy is weekly or bi-weekly. Gene therapy is just a single infusion. Is there an ability to impact the CNS? With ERT, definitely not. It does not cross the blood-brain barrier. With gene therapy, possibly yes. So what are the types of gene therapy that have been used? Well, we can use augmented hematopoietic stem cell treatment, where the bone marrows or hematopoietic stem cells are taken out of the recipient, treated with the gene and reinfused into the recipient. Or you can have liver-directed gene therapy. Now, the liver is a very effective way of giving gene therapy. So if you can somehow get the gene into the liver, then this forms a permanent source of enzyme, and it can be lifelong and very effective. In fact, it's been used for a number of conditions, not just POMPE. So here we are, 3 different approaches. Liver-directed is highly effective. The permanent supply, it results in immune tolerance. But in children, it may be less effective because obviously children's livers grow, so you get a dilutional effect, or potentially a dilutional effect as the liver grows. So this is a problem that needs to be addressed. Intravenous administration is effective, but it is very costly. And in addition, there is a very profound immune response to both the vector capsid and the transgene. Now, augmented HSCT has been used quite successfully. Way back as early as 2010, it was shown to have some improvement. In 2020, a much better result using codon optimized vector. I won't go into the details of this. You'll have to do some reading around this to see what is codon optimization. And importantly, this targets neurons. So can gene therapy via HSCT ameliorate or prevent CNS involvement? The answer is probably yes. You can see this study done earlier, reported earlier this year. On the left, you have untreated mice, and on the right, you have treated mice where you can see microglia with with the gene, rather containing the gene. They are appearing in the brain of these treated mice. What is the current status in patients? Well, on the website, clinicaltrials.gov, there are no fewer than 8 completed or recruiting studies on this website. But having said that, the safety and efficacy of gene therapy have not yet been proven in POMPE patients. So that brings me to the end of my talk. I hope I've only been able to skim the surface really, but I hope I've been able to give you at least a flavor of the current challenges and how we might go forward. Thank you very much.
Dr. Lokesh, you are on
Please
mute.
unmute.
Oh, sorry. So Thank you very much, sir. Dr. Ashok, sir. Now on summarize about natural history. This is one of type of LSD. Diagnostic approach by age. If before age 1 month is the infantile onset Pompe disease, and if there is a after 12 months, it's a late onset Pompe disease. Infantile onset Pompe disease usually present at 4 months of age, and if not treated, the demise can occur at 2-year age. The enzyme activity by diagnosis by chemical and clinical and biochemical analysis. Enzyme activity if less than 1% is infantile onset Pompe disease, and it is greater than 1%, late onset Pompe disease. Management, there is a if we can early start the treatment, the prognosis is better. Before 2 weeks, that's Kaushik sir said, or if we start before 6 months, or the patient before going to ventilatory support, the treatment is better, the prognosis is better. And the most important thing, the sir told, the CRIM, the cross-reactive immunological material status, prior to ERT. So we had to start the ERT, but we have to know the status of CRIM. If it is negative, so we have to use multiple immunomodulator therapy like rituximab and this. Iozyme and the newer drug next Iozyme also introduced for late onset Pompe disease. In recent advances, sir told the 3 challenges basis of taking a progress: the emergence phenotype, CNS involvement, and resistance to ERT. So emergence phenotype, IPD in infantile onset Pompe disease, the muscle weakness, spasticity, cognitive defect is there, and late onset Pompe disease is a smooth muscle weakness, hearing loss, etc. CNS involvement is same in infantile onset Pompe disease and late onset Pompe disease. We take the animal model, as sir told, there is a axonal degeneration, and there is a resistance of ERT. The sir told 2 says CRIM status, the explained by Dr. Kaushik sir. The CRIM status is negative. It is we used to immunomodulator therapy also, and the other one is autophagy. And the autophagy explain why we should start the treatment early. And the another one thing is TFEB. It stimulated autophagy. So there's a possibility overexpression of TFEB in Pompe disease to improve. And there is another thing is receptor problem. So there is a mannose-6 phosphate receptor is needed to enter the cell, the artificial enzymes. In Pompe disease, there is a very low density of mannose-6 phosphate receptors. So increased receptor density can improve the ERT therapy. For this, they use ERT plus clenbuterol. And there is another thing, next generation ERT, like next Iozyme, it is approved therapy, and better glucosidase activity like SIPA glucosidase combined with Migulest. The emerging therapy on experimental basis, the gene therapy. There is a 2 type of approach: liver directed or hematopoietic stem cell therapy. Hematopoietic stem cell therapy is more important. It can affect on CNS symptoms also, but all our gene therapies are on experimental basis. So this is the crux of today's talk. I would like to hand over to Mr. Saurabh Singh ji for vote of thanks.
Thank you so much to all the respected speakers for your wonderful inputs on International Pompe Awareness Day on 15th April 2022. Many thanks to our audience who are watching us today and becoming the part of this mission to raise awareness in the country. with all the support, now we feel that we are rare but not alone. One day we will definitely have their treatment, and one day we will definitely come when all the patients will have their treatment very smoothly. Thank you, Dr. Ashok Velodi, Dr. Kaushik Mandal, Dr. Lokesh Agarwal ji, for your precious time. Thank you. Thank you so much, and take care.
Thank you, sir.